Good afternoon, everybody. It's a pleasure to be here in Trieste. My name is Stefano Bergamasco from the Italian Clinical Engineers Association and also speaking for the Global Clinical Engineering Alliance. It's a great opportunity here in Trieste at EuroBioHighTech to have an international meeting with colleagues and friends from many clinical engineering associations across Europe. For those of you who participated to the International Congress of Clinical Engineering in Rome 2 years ago, we had a meeting in that occasion where the people that will speak today took a step towards the constitution of a European Clinical Engineering Federation. And after 2 years, of course, everyone knows that it's been a couple of very difficult years. We are now restarting our initiative with the aim to create this international body that is very important at regional level. In the meantime, things happened. Things happened in each country, but also internationally. So today we will have the opportunity to hear from our colleagues of different European countries their experience in clinical engineering during the pandemic. And this is very important and interesting to get lessons learned also from other countries. But also something important happened at international level from the Clinical Engineering Association's point of view. A new entity was created, the Global Clinical Engineering Alliance. First discussions also in Rome 2 years ago with international leaders like Yadin David, Said Khalil, Tom Judd and others. And it's my pleasure today to welcome here Mr. Yadin David, who is an interim president of the Global Clinical Engineering Alliance, and with me and other international colleagues, one of the founding members of this new entity. We will focus today on Europe, but we thought it would be very interesting for everyone to have a more global perspective and hear the reasons behind the need at every level, regional and global, to network between clinical engineers and clinical engineering societies. So, as the first speaker today, as a co-chair of this session, and I warmly thank him very, very much, I leave the stage and ask to turn on the microphone to Mr. Yadin David. Yadin, the stage is yours. Thank you.
Thank you, Stefano. Let me share my screen. Do you see my slide?
Not yet. I don't know, maybe, oh, there we are, yes. We see your desktop now. Maybe you have more than one screen on, Yadin. You should move the slides to the screen that is shared. Yeah, there we are. Perfect. Good.
Thank you. Thank you, Stefano. It's an honor and a delight for me to be part of this important event. And I'm bringing you the best wishes for productive educational program and stimulated conference from Houston, Texas, USA. Specifically, I would like to thank Diego Bravar, the organizing committee, and you, Stefano, for including me in co-chairing this important session towards the European Clinical Engineering Federation. And as you said, while the emphasis is on the European continent, I believe the pandemic shows us that no continent is an island, no country is isolated, and that we are very much connected and therefore professionally influencing each other region, and we should look internationally, globally, as well as regionally when we look at creating networking and professional groups. You know, to summarize, my message is that when you have a chest pain and you are seeking a consultation, and naturally you will go and look for the best cardiologist you can find. If you twisted your ankle, you will look for orthopedics expert for consultation. However, when you have medical technology related issue, then you may try to guess where policymakers and decision makers will go. Will they choose a biomedical engineer, clinical engineer? Will they choose engineer at all? And your guess is good as mine. And unfortunately, at the last couple of years, when WHO under Adriana Velasquez tried to create a group of biomedical and clinical engineering recognized profession by the ILO, the International Labour Organization, we could not get the clinical engineering to be recognized as a profession. So in looking at that, what I think that the challenge is in front of us is, first of all, becoming and sustaining a profession, a clinical engineering profession that has a boundary of knowledge, have a specific professional requirement as far as advanced training and code of behaviors and other traits that belong to the profession. We need to have education of health and wellness related community. Those are other professions like clinicians, nurses, administrators, and policymakers about the scope of our expertise. We need to advocate better academic program that's specifically looking at the point of care and towards how we solve problems and develop methodology that associated with life scenarios issues. We need to strengthening the capacity for engaging with policy creation, with regulation and decision maker relating to safety, quality, accessibility, performance, and effectiveness of health technology life cycle, and understand that those life cycles require specific management and ability to meet benchmark. We also a little bit weak about understanding the relationship between the patient, who is a customer of our services, and technological tool performance. In other words, what happened when a CT scanner does not provide you accurate information, or even worse, what happened when the CT scanner is not available for examination of patient in need of diagnosis? This relationship is something that we are not focusing enough and need to strengthen our understanding about it. We need to demonstrate, therefore, the derived benefits from our involvement at the point of care by not only providing the practice, but also study and perform research as to where do we need to go next. We have a need to put our representation of expertise with international bodies, including the ISO, AIIC, CN, WHO, etc., and to build recognition and impact through dedicated clinical engineering programs or organization. Therefore, the Clinical Engineering Alliance, GCEA, was registered and created as a not-for-profit organization created by clinical engineering, for clinical engineering, and uniquely dedicated to the field of clinical engineering. It does not have other flags. It carries this one flag, and it's only international organization that does that. It aims to maximize the benefit from healthcare technology and clinical engineering practitioners for the benefits of patients and their care providers, while minimizing technology risks and cost. Giving credit to Professor Dan Clark from the UK for this statement. To increase information exchange between engineering disciplines and clinicians, between engineering and administration, between engineering and regulators, and between engineering and policymakers, and finally between engineering and the public relating to healthcare technology. GCEA intend to provide international networking by taking group national societies of anesthesiologists, of nurses, of physicians, and build collaborations, build joint functions, committees, task force, and projects that will leverage our knowledge, competence, and professional services to empower optimal improvement in patient experience everywhere. To facilitate that, we have created a foundation, not-for-profit foundation, to encourage funding of this collaborative work, collaborative research, and the studies of point-of-care engineering and technological issues. This foundation will soon initiate a call for proposal and see what type of project the group would like to encourage and fund. The Clinical Engineering Alliance already initiated an education program that clarified this link between technology, engineering, and patient outcomes. The first webinar is scheduled this week on Wednesday, and then continuing every month will be a different webinar, and then courses coming to include things like project management, risk management, etc. We have completed already international review of technological innovation that address COVID-19 needs in low and middle income countries for World Health Organization under a contract, and resulted in this book that you see on the right here called the Compendium of Innovative Healthcare Technology 2021. To my knowledge, this is the first time that specifically clinical engineering profession has provided definition and mention in WHO documents or report. We also established and posted international recognition program where we will award excellence in specifically collaborative capacity building that recognize excellence in international clinical engineering collaboration program. So I hope you get the message where this alliance is going towards. We would like to lead professional tenets that include the issues of how do we know where the compass is and where it's directing us to go by convening Global Clinical Engineering Summit, Global Clinical Engineering Day that's coming on October 21st this year, Global Clinical Engineering Journal that has already published 4 volumes, and the 4th International Clinical Engineering Health Technology Management Congress that is going to be virtually this year for the first time. We are collaborating with international bodies such as IFMBE on the establishment of common professional threshold intended for the credentialing of other national national clinical engineering certification program. So in summary, what I'm seeing is that we have described a vision for professional future that bring the expertise that is needed at the point of care to manage and solve problem in collaboration with other professions, not just preaching to the choir, not just getting more clinical engineers, talking to more clinical engineers, but cross-discipline and work with other healthcare team members. It is a unified voice and therefore act as a professional organization that is qualified to represent the common interest of clinical engineering practitioners everywhere. We already developed and published several consensus and survey and are able therefore to advocate recognition of contribution made by clinical engineers to improve healthcare program outcome. And as we talk about COVID-19, silent hero list should include the clinical engineers who daily in the forefront provide for isolated patient care spaces, remote monitoring, breathing apparatus, and protection gears. Through the inspired leadership of GCEA, we will create alliances with other professions, and we will engage them in understanding better why we should have a seat in the table and why should we be part of the healthcare technology team? COVID-19, sadly and unfortunately, taught us that no one is an island, that we need to be better connected for the next disaster, and to promote professional education and credentialing standards. So we will become equal member of the healthcare wellness team. Because, as we always say, together we can make it better. I put a list of reference. I'll share the slides with you at the end. And I thank you very much for the time given to me. Grazie.
Thank you, Yadin, absolutely, really. I think that the key message here is for each of us to take action, for the different associations that today are joining this meeting and that I will reintroduce right now. The call for action is to consider joining the alliance at global level, at the same time to work at a regional level to strengthen the relationships that are so significant here in Europe for so many reasons that we will discuss during the meeting today. I invite you, Yadin, to follow with me the speakers today so that we can wrap up at the end of the session with a few key messages and appointments. So thank you so much, Yadin. Really appreciate your presentation. And I will give now the stage to our colleague Christophe Parret from France, from AFIB, the Association Françoise des Ingénieurs Biomédicaux, sorry for my pronunciation, so the French Association of Clinical Engineers. So Christophe, the stage is yours, 10 minutes, and then we go to the next speaker. Thank you very much, Christophe.
Okay, thank you. Thank you, Stefano. Yeah. I want to talk with you about the 2 points Stefano asked me. First is what's the experiences and lessons learned for crisis. And the second point is a position of AFIB about global international association on European Federation. The first point I want to share with you is the role of the engineer in France. With the crisis, the role of their technological expertise is very enhanced. And it will be very important because we work with the medical profession, with the care providers. And everybody know that our job is very important and is an essential support function in the hospital. And in particular, we are enhanced linked with the medical profession and hospital management. There are a lot of things we learn with the crisis, but this point is very important. And in particular, the expertise to buyers, because they are only the engineer. We know to understand the requirement of the doctor to define a good equipment for a good request. And for example, to find a respirator, yes, yeah, there are a lot of respirators, but we need a suitable one for the crisis. And if there are only one thing we learn of the crisis is this role for advisory role and near the medical profession and the hospital management. But we learn everything. Another point is very important. It's important to advise doctors, but we need to have an efficient maintenance department, and we need to have a local team, because when you are decide to put equipment in, we need people. We need people who know the equipment, the respirator, and we are more important. It's more important to have a local team because it's not possible to do that with other company not inside the hospital. I think it's very important for all biomedical departments. The other thing in France, we need to find a purchasing method to reduce cost. but we see with the crisis, the method of massification, for example, show us the limits, because we have only one supplier for one type of equipment. For example, one type of is a French company about a respirator. All hospitals in France work with this company, and the company is not big to answer, and is a very big problem. And we need, I think, we need to rethinking our purchasing methods in France. After, there's the coordination. For me, there are two levels. The first level is in France. And in France, there are three levels of coordination. There's a local, regional, and national level. And it will be very difficult to speak each other, and it's very difficult to learn from the experiences of the other. And I think the crisis, we need to work differently with the other colleagues in France. And I think it's a good step to speak about what coordination in Europe. And the federation should be a good solution. But for example, when there are the crisis in Italy, just before the crisis come in France, and the French engineer look at what, but not do something, because I don't know why, because we don't know how it's possible to help, or and you don't know how it's possible to use the experience of the other. And I think it will be very important if we have a federation to have a better answer at this type of crisis. If there are only one point to think about the crisis is a good benefit for our profession, because the crisis show at everybody her job. And in my hospital, for example, the crisis enhance the value of our profession, and in national country is sure, but perhaps at European level. Yes, it's only for the first part I want to share with you. For the vision about clinical engineer in an international or European country, I very agree with Yadin when he speak about a new alliance, global alliance, because it's very important, and we need an association that represents on a global level. It's important because when you want to work with WHO or other country or with NGO organization, we need that because it's possible to help to answer this other, to discover other health model, for example. And we think, AFID thinks it's a very important. We have a global alliance or other association at a global level to represent clinical engineer. But we saw in France how it's difficult to work together in the same country. Despite we have the help of AFID, the AFID work to create a link between engineers. We organize a day for the colleagues can meet and can work together. And despite it's very, very difficult. And I have just a proverb, a French proverb, say, far from the eyes, far from the heart. And I think it's very important, because if we need to work together, it's not possible if we know nobody. For example, in Europe level, I know a few engineers in Italy, one or two engineers in Spanish, and yes, it's not enough to work together, and we need and we wait a lot of things with the federation. And for the AFIB, we think it's very important to create something at a European level. Why? Because we obey the same grid line. We have a European directive, the same European directive. For example, I work as a new nomenclature. All European countries have the same nomenclature. We have rules, common rules, and perhaps we have common projects. And AFIB thinks is very important and want to increase links between people, and it's difficult to work at the global and European. We think it's a good thing. We have a global association, global federation, and another at the European level. But we are not sure have enough time to work in the two directions. And I think after we need to make a priority. And for us, the priority is to create link at a European level. But we are very agreed to work at the global level. We can develop this point at Milan. Just thank you for your attention. Okay, bye-bye.
Absolutely. Thank you so much, Christophe. As we also discussed in other times, yeah, it's kind of like, you know, think globally, act locally. We know that we have an open mindset at global level, but we must take steps locally. And between France and Italy, just to mention, a few more steps have been done, also because we are so close, just to tell the other friends so that we can follow also with other countries. Next week, you, Christophe, will be in Genova visiting one of our hospitals.
Yes,
and,
sure.
And a couple of our representatives will be in Lyon at your Congress. Thank you so much for the invitation. And as I mentioned at the beginning, we would like to invite all of you in Milan in November to our National Congress. So these are practical steps to bring people together, as you say. First step is knowing each other. And today is another opportunity to get to know each other towards this, because there are institutions, but they are made of people. So if we want to build a European Federation, we must network between people. So thank you so much for your message, Christophe. And I would move in our tour across Europe from France to Germany. I invite to open the floor to Frank Rothe of the German FBMT, Fachverband Biomedizin Technik, the German Association of Biomedical Clinical Engineers. Thank you so much, Frank, for being here today. We've been meeting last time in Medica Düsseldorf some time ago, and then COVID came in between, and it's really good to meet you, even though online now, and hopefully soon in person, very soon. I leave the stage to you, 10 minutes. Thank you so much, Frank.
Thank you, Stefano. Hello, everybody in the community. I'll try to share my screen. So are you able to see my presentation? I hope so.
Yes.
Okay, then let's go roughly through it. Thank you for giving me the chance to present what's going on in Germany. First, let's talk a little bit about the COVID pandemic lessons we learned. Activities in Germany is supported by clinical engineers at the moment. We implemented a system of continuous monitoring of ICU beds nationwide, referring to diseases, capacities, and stuff like that, to quit from the usual monitoring characters and to really be able to see what's going on concerning COVID-19 and other diseases. That is implemented German-wide. German-wide, we are having created working groups working on alternative or sometimes on autonomic supply chains for critical goods. We have learned that it is not reliable rely on the international markets. At least we got some trouble to get stuff really needed from those easier regions. So we're setting up supply chains and for critical goods and autonomic supply possibilities. For example, we switched some enterprises to fabricating face masks. That was pretty easy with some companies to do that, and that's what we are going to set up at the moment. We support that. Then we give advice to our national council to implement national storages for critical medical devices and critical medical goods. And there's a project set up called critical infrastructure. So what we do is we're defining critical infrastructure and creating and improving disaster plans in case of other pandemics or other catastrophes. That's what we have learned from COVID-19. Some news from the German FBMT. We've had elections that September, and there's a new board of directors. I'm pleased to be a member of that board of directors too, and I think they'll set me up to be their Minister for Foreign Affairs or something like that. So that'll keep me in touch with that group, which I really appreciate. The old president, to your information, Stefano Siebold, has quitted due to his age. He wouldn't want to continue his work. And we got a new president, a lady president. Her name is Dubravka Maljevich, and I will introduce you to Stefano as soon as possible. So yeah, what we hope, or what is our intention in that group, what we hope, what we can improve is, of course, there should be I'm only looking at the European Union and the European level on that slide. That's why I understood how I understood the task. What we would like to have is a special interest group, really representing the special interests of clinical engineering in Europe and the European Union. Doing some work like lobbying. I think that the lack of lobbying for clinical engineers in Europe. I think it'll be good if we succeed in supporting the European Union when they're working on the medical device legislation, and legislation that is in the field of clinical engineers. We think it's good to be already in that topic during they invent it, then claiming afterwards the lags. So if we could get in that position that we can support them, and they ask us if they create medical device legislation on a European level, that'll be great. We would like to support that actively. What we want to do is supporting the clinical engineering community in Europe, and if so wanted, also worldwide, with experience exchange, setting up best practice standards, creating networks and information exchange platforms. That'll be great, and we would like to promote a European-wide alliance of clinical engineers as well as a global alliance. So that's what I get to present. If there are questions, I'll be happy to answer. Otherwise, I could pass the screen to the next.
Yeah, thank you, Frank. And first of all, so congratulations and welcome to your new president, Dubravka. It will be a pleasure for us, but not only for me and our Italian colleagues, but for all the team here from across Europe to meet her and keep discussions with you and the new board. So that's really good. And I took a few notes about the keywords that you mentioned about the goals and advantages of a EU federation, like lobbying, developing legislation and experience exchanging. So I think these are interesting key points and good message for our work to continue. So thank you very, very much, Frank, for your presentation and for your association to be part of this network. Now we go to Spain. Another country where we have very strict relationships in terms of collaborations between our associations, and I welcome Raquel Canovas Paradell of SEIC, la Sociedad Española de Electromedicina e Ingeniería Clínica. I had the pleasure to participate to your congress a couple of years ago, and during the emergency in March, you participated to a webinar that we held with the colleagues from other European countries, and your presentation was very much appreciated. So Raquel, thank you also for being here today, and I leave you the stage and the screen. Please open the mic, and the stage is yours. Thank you so much.
Hello, thank you. Can you hear me?
Yes.
Okay. First, I want to thank the organization for the invitation. I want to thank the Italian Association of Clinical Engineers, but in particular to Stefano Bergamasco, who is the soul of the European Clinical Engineer Federation that is going to be born, I hope, soon. To congratulate Yadin for the initiative of the global organization. And I'm really happy to see you all after 1.5 years, the last time we talked, that you are all safe and sound. And I would like to share you our experience. We talked in April 2020, 1.5 years afterwards. I think we are much better. Spain is definitely much better at the beginning. So the tsunami started in China, then in Europe it arrived to Italy. Stefano knows very well. And in Spain it was Madrid, Barcelona, and La Rioja. So we were completely saturated. Now we've got the second, the third, the fourth, the fifth waves, and we have the population almost fully vaccinated. So only the children need to be vaccinated, but all critical people are being vaccinated, and the healthcare systems are stabilized. So we are much happy now than the last time that we saw each other. Just to show you the experience in Vallebron, no? As I explained then, I don't know how this virus works, but it was concentrated in Barcelona, Madrid, and La Rioja. So the systems collapsed there. We had this is the image of the incoming patients and the critical patients, the NIC intensive care units patients in Vallebron. So after the first tsunami, the second, the third, the fourth, and the fifth wave were really easy to overcome. What did we learn? As I spoke the other day, I believe that the hospitals should review their design and should be more elastic, but not only the hospitals, but also the healthcare systems. I'm very happy to see that the Germans are already organizing this share of our management of beds. We are also doing this in Catalonia. There is what we learned that it's very important to have a medical device stock. Now it's EQ ventilators, but there should be other types of equipment that we should define. The adaptability of the professionals was key, and they need to be trained in this adaptability because they did it very well, but they didn't have the tools. They did it by nature, by adaptability and by survival skills. No, what we did very well was the management of hospitalized patients in hotels and pavilions, and the network of technicians in Spain work also very well. So that's why I'm also very happy to talk about collaboration, not only within Spain, but also in Europe. There were some other things that did not work so well, but let's talk about the positive things. As I explained you, we doubled the capacity in the hospital to 100%. So from 90 beds to 100, we opened 140 more, and we had 50 more ready. We also built 5 floors of the hospital in a sports pavilion. So that I think that the flexibility and the adaptability that we showed was very high. As I said, and I won't be tired of repeating, stock is crucial. So I think we have to think, not only us, but we have to push a little bit the industry to rethink the model of working on medical devices. And I think that medical devices are a strategic device, so a strategic use issue. We have a reserve of gas, of energy, but we don't have a reserve of medical devices or healthcare supplies in general. So getting to the point, which was a little bit the anecdotes of what happened in Catalonia, in Spain, and in our hospital. I believe that we need a systemic innovation of the whole healthcare system, in the sense that we need to adjust the capacity. When we talked the first time, we had different number of intensive care beds per capita in Europe, completely different. The top 10 were the top were the Germans, and we were going down. Spain was the one that had the lower capacity. We have increased this capacity. We have made new hospitals that have this elastic concept and double function. They can be used as intensive care units. They can be used as daycare, as outpatient. So are infrastructures that have been done for COVID, but can be used, can have different uses. And in the case of emergency, the use can change. And I think this is very important. Cluster management of intensive care units within the country or the community and emergency areas, it's very important. And this has worked very well in Catalonia. That is the reference that I know. But common IT information tools need to be deployed, governance needs to be deployed, and telemedicine has grown. That is one of the nice things that COVID has brought into our country, telemedicine. And also the knowledge that there was a need to invest in medical devices and in building extra hospitals. For me, the medical device industry needs to review their stockage strategy, because they only have they depend too much on parts and pieces coming from outside Europe. And the big crisis, there was a lack of parts, a lack of devices, a lack of everything. And I think that we need to promote local industry in Europe, but as in the States, they need to promote their industry, because transport in these circumstances are very complicated. And contingency plans need to be defined. Also, professionals, as I said, this is a systemic innovation. Everyone has to innovate, no? Politicians define the new healthcare system. The medical industry has to rethink how they work and how can they supply what the demand requires. I know this is something that got us, everybody, by surprise. We didn't thought that tsunami was going to be so big. And professionals, I think, as I said, the adaptability of the doctors and nurses was key, and it was really impressive. Seeing pediatrics intensivists and neonatal intensivists working hand to hand with adult intensivists and helping them to do their not so much specific work for adults. It was nice to see, but I think that some training in this field should be required. And clinical engineers, I think we had an opportunity to stand up, and we had a lot of recognition, public recognition, and congratulations. But I don't know if we managed to collect the results of this public recognition, no? And I think the European Alliance makes a lot of sense because of the level of regulatory, the level of lobby, and the things that we can do together in Europe. And one of the main goals is to put the place of the clinical engineer where it should be. And we are really willing to go forward with this initiative. And the Global Alliance is on a different scale and has different strategies, as it was explained to us early this afternoon, no? And I think both have a reason to exist, and both has a role to play. So we are looking forward to see how all this goes on. And that was, I think I'm in time. Yeah. That was, thank you.
Good. Thank you, Raquel. Really a pleasure hearing your experience. We had so much in common during the peak of the emergency between Spain and Italy, as very badly hit by the COVID in March, April last year. And we took your very interesting message also before in other occasions that we discussed about the elastic hospital and elastic healthcare system, and what you told us today about systemic innovation. I think these are really key concepts. And also, it's good, one of the good elements, if we can say so, of all this bad situation is the public recognition of clinical engineers. Also, the non-experts started talking about patient ventilators and medical devices, and this is probably a key strategic moment for our profession globally. So thank you so much again for your presentation here today. And as the next speaker, I would like to invite the colleagues from Ireland, and in particular Brian Kearney from the Biomedical Clinical Engineering Association of Ireland. Thank you so much, Brian, for being here. Thanks also to the other colleagues that I had the opportunity to meet at one of your meetings again a couple of years ago, because yeah, it's like a kind of a small blackout of 2 years now, but we hopefully will recover soon and meeting in person again. So Brian, the stage is yours. Thank you so much for being here and bringing us the point of view of Ireland.
Thank you, Stefano, and hello everyone from Ireland. So can everyone see my screen?
Yes.
Great. I'm just conscious of the time, and I don't want to repeat what other people have maybe touched on, so I'm going to fly through this if that's okay. And I know, Stefano, you want to take some points at the end. So yeah, just saying hello. I just said I'd give a brief background just very quickly from the engineering point of view in Ireland. We would always look at it as this tripartite thing of hospitals, academia and industry, and we would see our organisation as trying to bring the three of those together. I suppose at the same time though, we always try and just make sure that we keep that patient piece right at the centre of everything we're doing. So we keep drawing back every decision and every discussion we're having into how does this benefit the patient and the service user. Again, as well, presented on this briefly before, and just looking at healthcare and looking at how clinical engineering can assist in management of things like COVID-19 and how they can be very useful expertise within the healthcare system. I would have described the healthcare as a kind of a two-headed monster. So you've got the medical and non-medical professionals working together, and we're all trying to deliver patient care in a very changing environment. We know that clinicians are very knowledgeable in the treatment aspects of patient care, but the healthcare management teams are very knowledgeable in terms of managing the various functions of the organisation. And I suppose it's how we bring those two bits together is often where I see clinical and biomedical engineering coming to the fore. So previously I would have identified, and we would always discuss, as many of my colleagues have discussed, the healthcare challenges that were there. And these were all here on the screen before COVID-19. Things like the aging population, the workforce challenges across Europe and across the globe, the movement of technology and data, and the explosion of data in terms of healthcare industry as well. And I suppose when you add then COVID-19 to this, and you look at the last year and a half to 2 years, the challenges have only got greater. But I think when you look at the definition of what a clinical engineer is, and we go back to 1992, and we look at how it's a professional who is ultimately applying engineering and managerial skills to healthcare technology. I think that's a very important point to bring in terms of engineering. We know that the profession knows and respects the clinical environment, We know that they understand the terminology, but we use engineering practice and methodologies as a standard for how we work, a scientific basis to everything that we do. And we specialize in this role. And I think Dr. Yadin brought it up recently in terms of just about who do you go to for these things. And I think it's important that we brand ourselves as a specialist in terms of healthcare technology and how we optimize the treatment of our service users. So if we look at COVID-19, I just had two strands. One was organizational and one was technical in terms of the importance of clinical engineering. And I think organizational wise, certainly in Ireland, our professional clinical engineering, I felt, brought people together. We're able to translate the language between the clinical and the technical. And we were central into a lot of the decision making that happened in the acute hospital sector. We sat at the top table and made some very large data sit together to inform service decisions and basing it on facts and figures. We also looked at how health technology management should happen with non-HTM people, improving the quality and the patient safety aspects of what we were doing. We also are key to project and change management. So organizationally, change management is a massive factor in terms of what we were doing. And over the last number of years, I'll come back to it, but I think there's been a level of fatigue in this area. If we look at the technical side of the importance of what clinical engineering we're doing during and after COVID, it's adapting to new technologies in such a short time frame. So new devices coming on stream. Very often the devices that we got during COVID, as we all know, there was very limited or no training available, maybe no manufacturer support. We had devices arriving from all different jurisdictions and areas around the globe that we didn't necessarily have all the information for. That presented a risk for us in clinical engineering. We're front and center at trying to mitigate that risk. I think going forward, we need a central repository for information like this. And I think going back to Stefano's piece about the European area, that this could be a really important part in trying to gather a repository of information and training materials. Also, technically, we were involved in like pop-up acute beds, ICU beds, bringing them on stream in a very short time frame, managing the stock that's there, integrating with our ICT colleagues. So in Ireland anyway, ICT is separate to clinical engineering, but yet we all know that one can't happen in the healthcare system without the other in many ways. So we have tended to, in the last number of years with clinical engineering, not just focus on medical devices. It's health technology, it's healthcare technology. It's integrating with your networks. It's looking at network security. It's looking at IT systems. And within all that area, we're trying to align to some existing practices, if at all possible, to use this technology rather than introduce in new areas. Things like the management of medical oxygen during COVID was had clinical engineering right at the forefront in terms of trying to manage pressure drops in the acute hospitals with high flow devices, trying to work out the balance between the nurses and doctors wanting all their respiratory expertise in one ward, which made perfect sense, have them all in one area where they needed to be cared for. But yet if we put a lot of high flow devices into that area, the oxygen level and pressure will drop in the system. And how do we try and mitigate those factors and balance that risk? Also, things that aren't directly clinical engineering related, such as facilities, air handling systems, filtration, looking at HEPA filters, looking at panel and bag filters in terms of our infection control colleagues, and items like air changes, and trying to help the technical services department to work through that stuff. And then lastly, community and home device support. So in Ireland, we have a sporadic support system out in the community in terms of clinical engineering. And I think that's an area that we need to focus on over the next number of years. We have a big strategy called Sláintecare, which is about bringing healthcare to the home at the right time in the right place. But we need support of our technical expertise out in the home, not just in the acute hospitals. And we have some level of it, but we have a long way to go yet. If we look at some of the lessons learned, and I reflect back on how the last 2 years have gone in Ireland, clinical engineers being involved at the top table, it's a great expertise and not just medical device related. So again, being able to influence those decisions, making the best of what we have. And I think given some assurance that maybe not being perfect is okay. So rather than trying to achieve this 100% perfection before we roll out a device or technology right now. We had to accept during COVID that we mightn't get to that point, and we had to weigh up the risks and say we need to deliver this technology. And once the clinician is on board, is aware, and we do a risk assessment on it, we sometimes have had to put out technologies that we wouldn't maybe always have done so in such a short space of time. So I think being a little bit more comfortable with that piece and just taking a balanced view on it has been an important lesson. And the last point I'll just make is about fatigue, and this fatigue post-pandemic. So, you know, we're thankfully, hopefully coming to a different phase of the pandemic. Certainly in Ireland, things have started to stabilize and are in a relatively good place. But showing our ability to change and adapt and cope with ongoing healthcare challenges, they're all there, and the workforce is tired, is a little bit fatigued from it all. And it's nice and refreshing to see the resilience involved. We recently had a very significant cyber attack on our healthcare services in May, and we were just coming out of that really intense period of COVID, and then bang, all our systems were gone. So, you know, it's that lesson of looking after your staff, the health and well-being of your staff, giving people enough care and attention within the department to, as I say, like on an airplane, putting your oxygen mask on first and then looking after everyone. You need to look after everyone and make sure that they're healthy and able to continue and provide the service. Just in terms of the international collaboration, and I was in Rome in 2018 when we discussed this European Federation, and I think we were all in agreement that Europe needs a strong voice. I think Europe their circumstances may differ from other regions across the globe, and I think we need to be able to display that in the right way and be able to communicate that to the right stakeholders. Ireland have been a long-time supporter and contributor to the IFMBE, and also to its clinical engineering division, and with Dr. Yadin and Tom Judd in terms of the Global Clinical Engineering Alliance. So we want to keep those relationships going. We ultimately believe that we need to work smarter, maybe not harder, and learn from others. So we're really open to trying to create this European alliance of people who are dealing with similar standards, regulations, directives, and to learn from what they're doing and how we can apply it here in Ireland, and also maybe share some of our learning with colleagues abroad as well. I think a clear example of this learning from others is the CED Hacking Coronavirus Initiative, which has worked very well in my opinion. And ultimately, I suppose I believe that the objective is to create closer collaboration across Europe. I think we're talking the same language, sharing resources, and, you know, making sure we ensure there's a strong voice, but that is not diluted by various strands of maybe similar voices. So I think that's probably the only caveat I'd have, is that we make sure that we have a strong voice that's not diluted. So Stefano, I rushed through that just to get you on time, but I hope you could hear me okay and that's okay for you.
Absolutely, and your presentation was full of interesting concepts. I would like to ask you, but also all the other speakers today, to share their presentations. I think they are a very good common ground to build upon towards the new federation, and also about the lessons learned. As you were talking, for example, organizational and technical challenges and lessons learned, the difference across medical and non-medical professions. These are key elements that have practical consequences. Just to mention one of the experiences we had here in Italy, a challenge of clinical engineering not being considered a medical profession. When early this year in January and February, physicians and all other medical professions got the vaccinations as the first group of professionals as the front end with the patients, a lot of our clinical engineers colleagues in Italy couldn't get it because they were considered an administrative profession. It's crazy because we work on the front end with medical devices in the wards, but it is about the bureaucratic labels. Are you a medical profession, a non-medical profession, and so on? So having a single voice to bring these concepts, of course also sharing the technical challenges and learning from the technical point of view, but also the organizational issues that you clearly mentioned, I think are very important. So thank you so much. Let's share the slides with all the group. It will be very useful, and your contribution both to the European initiative and at global level is very much appreciated and important. So next speaker, I will ask to Roland Leuven from Holland, the BMTZ, the Biomedische Technologen in de Zorg. We have here the Dutch clinical engineers. We have a long-standing collaboration with some of you guys, and it's very good to have you also in this meeting today. So I don't lose any more time. Roland, thank you so much for being here, and the stage is yours.
Thank you, Stefano. Thank you for your invitation. It's good to continue where we left off some 2 years ago. I remember visiting the conference in Rome, which was great, and well, having our joint intent to to increase the recognition of the clinical engineer and start a European federation. I prepared some slides to show you the Dutch things that happened in the Netherlands. Let me just quickly, the clinical engineer in the Netherlands, we're still a small association, quite new, but we work in the field of the medical technology and in between the medical technology, the clinicians and the management. And this is the field that we work in, and especially during the COVID, we could also show our added value to, during the COVID emergency. COVID in the Netherlands, there was already a lot of explained, I think, in the other talks, but the way we saw it in the Netherlands was that it's also, you could see that it was not equally spread throughout the country, and you saw major differences between regions. It started out in one region and gradually grew, after some time we were able to set up a national coordination of distribution of patients and resources, and that really helped in covering and making sure that we have enough beds and resources available. And as a clinical engineer, we had an important role during this pandemic to ensure the safe implementation of all kinds of new but also increasing the existing devices that we're using, medical technology, the introduction and also the use of medical technology, and making sure that the staff could use it safely. And what we also saw that we had to increase the ICU beds quite quickly, and also we have now implemented a structural increase in ICU beds for the future. And then the main lessons learned that we saw was, you saw that there was a huge improvement in the collaboration between hospitals nationally, but also internationally, which was great, I think. Sharing knowledge, sharing experiences, it was great. And another lesson learned was that we had a quick response. We had to quickly react to solve challenges, and you saw that people stood up and of different groups within, but also outside the hospital, all wanted to cooperate, and it really was a teamwork effort to get this challenge solved. And also, it helped in accelerating the innovation, implementation of innovations in technology in the Netherlands. Then short thing about the European Federation. Our main goals have not changed a lot since we shared the intent 2 years ago. We think it can really help in strengthening the recognition and added value of our profession as a clinical engineer in the Netherlands, but also in Europe and globally. And we can support each other and exchange experience between the associations, which we are doing already, but we can of course, improve this even more with the European Federation of Clinical Engineers. And it also gives the chance to broadly exchange knowledge within the field of clinical engineering, which is a great thing to do, I think. Thank you for your attention.
Thank you, Roland. Yeah, your last slide, I think, really brings a clear message. Both aspects, the recognition of the profession towards the decision makers at political level in every country, but also at European level, and the exchange of information. One of the things that we in Italy feel is very important of these international networks is that, of course, at the end we have to sit with our local politicians for recognition of the profession, and the same for you in Holland and Germany and so on, but having the strength that we can tell, look, this thing is going on in all European countries, and we have common goals and common issues, gives also local power to all of us, big or smaller countries. So I think this is really a key message, and we have to work hard towards these goals, but I guess this is the clear intention with all of us. So the direction is set. So thank you so much, Roland, and bring also our hello to all your colleagues in Holland that we had the opportunity to meet in other occasions, and let's meet again in future on in-person opportunities. Now we move to Greece. We have Haris Dermitsakis from Elevit, the Hellenic Society of Biomedical Technology, and I really thank the Greek Association of Biomedical and Clinical Engineering for being here with us today. It's a long story of relationships with people like Nicholas Palikarakis, just to mention someone we have a strong relationship with, but Aris, it's really a pleasure to have you here with us today. So I leave you at the stage and ready to listen your experience. Thank you so much, Aris.
Thank you very much. I will share with you my experience of the Hellenic Society of Biomedical Technology and the actions that we took during the COVID pandemic. First of all, let us introduce ourselves. Hellenic Society of Biomedical Technology is a society that has over 100 active members. It was founded during the 70s, and we're having offices in both big cities of Greece, Athens and Thessaloniki. Elevit has an international presence for many years now. It is a member of the International Federation of Medical and Biological Engineering. It's a member of the European Alliance of Medical and Biological Engineering and Science, EAMBES, and it is a member of the newly created Global Clinical Engineering Alliance, GCE, which is, we had also the pleasure to be one of the first members to join GCA family. Now, during the COVID pandemic, as you all know, the pandemic gave the clinical engineers the opportunity to show how important their work is and how absolutely necessary it is to have strong clinical engineering departments inside the hospitals. The clinical engineers were in the front line of a fight with the COVID-19, and we had an extraordinary mobilization of clinical engineers worldwide. Leading in these actions were the Clinical Engineering Division of IFMB, WHO, and GCA initiatives, which were followed by numerous national and regional societies, including our own society, LFE. Now, in order to focus more on our stuff here in Greece, so the main challenges were was that we had the biomedical technology projects that were at the front line in order to contain the spread with the use of masks and to wipe out the disease in the use of vaccines. At the same time, the clinical engineers had to make sure that they were doing we had a correct management of the medical devices available in the hospitals, and also of the donations, because as you know very well, there was a huge wave of donations through all health systems, but a donation, in order to be effective, it has to come and fulfill real needs of the hospital, let's say, or the medical unit, and not just be a donation of whatever. This health crisis had affected public and private sector operations. And one of the main challenges that we had, it was the challenge of disinformation. We had a lot of disinformation regarding the COVID-19 pandemic, which magnified serious public health issues and put pressure in health systems. At the same time, also undermine efforts to control the pandemic. In Elevit, we received many questions from our members. Some of them were, let's say, an example, especially in the beginning of the pandemic, that not so much information was available in the public. clinical engineers were asking that how to treat devices that have been inside a room that there was a COVID patients, and they were very scared of even making a repair on this machine. So we started a series of educational programs here in Greece in order to educate all clinical engineers and other experts in the area. So we aim to engage biomedical and healthcare technology stakeholders and practitioners in Greece in a series of webinars and congresses, and we measured also their responses. Our key target audience was procurement experts, policy designers, healthcare workers, biomedical technology departments, and clinical and biomedical engineers. We had a series of webinars. We had 5 webinars during May to December of 2020. It was about clinical engineering and medical technology in the COVID era, health providers and procurement, management of critical equipment, medical mask technology and vaccine technology. We had some technical seminars from manufacturers in order to educate how to correctly maintain and use critical medical devices. A series of webinars on health technology assessment of medical devices. We participated in the FMB CED webinar series, and one of the latest that we had, it was the organization of the 9 Panhellenic conference, which was organized alongside with the Aristotle Medical Forum. It was a 3-day conference on biomedical and clinical engineering, and we had the great honor to have see the clinical engineering worldwide leaders participating in this conference. As you can see, we had the lead of medical devices and individual diagnosis of the WHO, Adriana Velasquez, chairman of CED FMB, Tom Jude, President-elect of FMB, Ratko Majarevich, President of AMBES, Leandro Pecchia, and active President of GCEA, Yadin David. We thank them very much, and we were honored for their participation. Among our actions, it was the organization of other seminars about the risks and safety in healthcare facilities, including electrical safety, radiation hazards, hospital gas quality, new technologies, etc. And as I told you, we were also doing some polls about how the educational outcome of these webinars was going. So at the beginning, we had more about 100 to 140 participants during the first webinars. We have 275 participants during the mask-related webinars and over 800 participants during the vaccine-related webinar. Now, we were asking questions about before and after the webinar in order to be able to compare the results. So just an example to have here, for the last webinar that I told you, the vaccine webinar, we were asking the simple question, are you willing to receive the COVID-19 vaccine? So before the webinar, the willingness was about 43%, 13% said no, and 44% were skeptical. After the webinar, the people that said, yes, I'm going to have the vaccine was up to 63%. The ones that said no dropped down to 3%, and the skeptical ones also decreased by 1/4. The interesting thing is that although they were a bit hesitating about the COVID-19 vaccine, you could see that they were clearly much more trustworthy to the rest of the vaccines. The same thing, just a quick result, it was done also for the masks and the protective gear to use, in which we had some questions about the correct use of protective gear and mask before the webinar and after the webinar, and there was a very good shift about people learning how to correctly use all this equipment. Now, towards the EU Federation, Elevit is always in favor of international collaborations. As I have already told you, we are a member of FMB, AMBES, and GCEA. Recently, we created also a chapter of clinical engineering in Elevit. And Elevit has and will always support collaboration between clinical engineers in Europe, because we know that this is very important to exchange knowledge and information from such a collaboration. And we generally support the idea of an EU clinical engineering entity, providing that critical number of national societies will participate in that. Thank you very much.
Thank you, Aris. And yeah, your last point is really a strong point, a critical number of national societies. Here today, we are like 10 of these associations across Europe. There are countries where we have seen also 2 years ago when we started thinking and networking that there is no clear clinical engineering association, maybe something more in the lines of biomedical engineering through the universities. I think that if we start with this group, it's already a significant portion of clinical engineering across Europe. Congratulations to Greece for being, I think it was the first society that joined GCAA.
Yes, yes, yes.
You beat us, we joined a few weeks ago. And one strong point that you put, I never thought about that as a strong role of our profession also, is fighting disinformation on COVID-19. From our perspective, and with the clinical engineering division, with the COVID-19 series of newsletter, this was done. I think it's really a good point to bring our profession advocating for correct information on these issues. So thank you so much, Aris, for your contribution. Really looking forward to going on through this path and continuing these ongoing relationships. And our best regards to Nicolas and all the friends of your association. So I would like now to move on to our last speaker, but as they say, last but not least, I would welcome Leila Gurbeta-Pokvic from the Bosnia and Herzegovina Medical and Biological Engineering Society. Through Leila, I would like to say hello also to Almir Badnjevic, our friend and colleague of the Bosnia and Herzegovina Society, and really a pleasure after we met in Bari, the Mediterranean meeting of clinical engineering societies. We met again in Rome in 2019, and here we are ready to start again our conversation. So Leila, the stage is yours. Thank you so much for being here.
Thank you, Stefano. Hello to other colleagues as well. It's nice to be here today with you and talk on this occasion. So I'm going to present Bosnia and Herzegovina case study and some thinkings of Bosnia and Herzegovina Medical and Biological Engineering Society. So just to put my story into the perspective, I'll give you a few statistical information regarding Bosnia and Herzegovina. You can see that it is classified as upper middle income country of 3.3 million people. And here you can see that we had first confirmed COVID case reported on 5th of March 2020. And you can see that the mortality rate of COVID patients in Bosnia and Herzegovina is unfortunately pretty high in respect to the coronavirus cases that are reported. So unfortunately, I don't see in public that anyone is asking the question on why this mortality rate is so huge. So during the previous period, Bosnia and Herzegovina was even put as on the first place regarding the mortality due to COVID-19 virus in the Europe. We rarely go in the first position in European region, but unfortunately this was the occasion. And I can say that everything we learned during this crisis was actually learned from bad moves, which were coming, unfortunately, from the politics and from administration. So what did we learn? Instead of promoting and enhancing mutual cooperation for the common good, the relevant institutions and leaders were divided, and they are still divided on an entity, cantonal, and national basis. So this caused a complex situation within our country in respect to fighting COVID-19. So at the very beginning of the pandemic, the image in Bosnia and Herzegovina, as in the rest of the European country, was created that clinical centers, hospitals, and healthcare centers do not have the necessary equipment to treat COVID-19 patients. So therefore, in our country, an urgent procedure was adopted, as in other countries, the medical devices which were lacking were mechanical ventilators. So they set up an urgent procedure and they started the procurement of mechanical ventilators. And that was a big affair in our country, but I'm not going to speak about that. I'm just going to point out that it took some time to procure these mechanical ventilators, and then it took 1 year to put them into operation in healthcare institutions. So we were asking ourselves, okay, what was that urgent need if they can sit around for 1 year and not being used in healthcare institutions? So from this, what I'm telling, I'm coming to the point why clinical engineers are needed in Bosnia and Herzegovina, because during this urgent procurement procedure, I'll say not a person from clinical engineering profession was asked to design minimum specification for mechanical ventilators, and they didn't even discuss the environmental conditions or the environment in which these mechanical ventilators would be used. So even a year after the beginning of the pandemic, no one still knows the right path of the patient, because healthcare system is facing the labyrinth of bureaucratic anarchy, and it is the patients who suffer the most. One thing also that we learned is the problem of collecting data on patients in a single register. So nowadays, unfortunately, in our country, you don't even have an integrated number on people who got vaccinated, fully vaccinated, or just with one dose, or even just got vaccinated. And the vaccines, if I mention them, they open just another field where our administration fell apart because there were unclear responsibilities for vaccine procurement. So what did we learn? And now I'm going to repeat what my colleagues said in their previous presentations. So we learned that the voice of clinical engineers need to be heard louder. So heard louder, especially when urgent procurements are made or medical technologies distributed in environments that are different than usual clinical environments. And we did some work on this basis. So we analyzed the emergency use authorizations for import and approval of medical products, and we concluded that they should be narrowly specified and clearly targeted from case to case. And we see this as a gap that can be filled with clinical engineering professionals, and that is one benefit of having international organization representing clinical engineers. So going through all the emergency use authorizations and emergency use of medical technology, we summed up some guidelines. For example, to define and make available minimum technical specifications for essential medical products and treatments, to define shorter versions of emergency use authorizations for essential medical products, to define minimum requirements for production of essential medical products in extraordinary situation for non-medical manufacturers. A colleague from Spain mentioned how car industry or military industry can be transferred into producing medical devices in these urgent situations. But I think that clinical professionals need to define these minimum requirements or just a guideline for these manufacturers. Also, one guideline that we also propose is to create a national, international inventory database of medical products, because in Bosnia and Herzegovina, maybe there was not obvious lack of mechanical ventilators. And one colleague said patients of COVID-19 were not distributed evenly by regions. So that was the situation in Bosnia and Herzegovina as well. So some of these medical devices could be shifted in these urgent situations just to overcome their lack until they were procured. So we also learned that from this emerging and still ongoing pandemics, that the proper way of collaboration between institutional departments first, because it is hard to position the clinical engineering department in the institution in a country such as Bosnia and Herzegovina, where clinical engineering professionals working in healthcare institutions, they are just technicians. What do they know? And when you have the lack of medical technology, the extreme need for medical technology, then they remember that these people exist and they ask them, but not in a proper way. So we need to ensure the positioning of clinical engineering divisions within the healthcare institutions, then within the national bodies, and for example, inspection laboratories, as one is where I'm working here in Bosnia and Herzegovina. So we, as a medical device inspection laboratory, regulatory, let's say, a body with appointment from the country for the inspection of medical devices, we had a lot to do during this COVID-19 pandemics, and we faced all sorts of medical devices. And for example, these mechanical ventilators that were imported, they were not functioning properly. So we measured their basic parameters and we found out that their performance is not good, that they are producing more volume into the lung of the patient, and they really found this part which needed to be adjusted in order to put the performance of these devices into these technical specifications. So having in mind the Industry 4.0, the digitalization and everything, I see that clinical engineers need to collaborate just to provide the right data nationally, regionally, and institutionally as well, because having all this data gives us enough insight in what is going on in the field. Now we are discussing and we are sharing experiences country from country, and we can see, for example, some good practices from Italy, from Spain, from Ireland, and for sure my country could benefit if we have a way on how to transfer these good practices in our country. Thinking about international clinical engineering collaboration, I started from the definition of clinical engineer, as well as one of my previous colleagues. And I saw some keywords being education, experience, and accomplishment. And in today's environment, I think that these key words, key attributes are crucial for maintaining medical technology, but not only medical technology, but the transformation that is hitting the world. Today, data is the currency, and as a profession, we need to adapt to this. So therefore, we see a strong clinical engineering collaboration internationally and at the European region, with the aim to establish knowledge-empowered network, as previous colleagues commented, in order to foster the uptake of skill in clinical engineering departments throughout the countries. This, in my opinion, will stimulate better preparedness to critical situations such as this COVID-19 pandemic. One crucial thing, in my opinion, is to work on standardization of maintenance and surveillance techniques. A few days ago, I had a discussion with colleagues from United Kingdom, and we discussed about different maintenance techniques of medical technology within clinical engineering departments across United Kingdom. And when I asked him, okay, how do you trust in one device in one healthcare institution and you don't trust in performance of other device in other healthcare institution, he said, look, the maintenance is done based on best practice of clinical engineering department, and I believe that. And that's fine. I'm not questioning the experience of clinical engineering professions. I'm just talking about making an evidence of that trust. If we say we're doing everything, then we must ensure standardized evidence-based system. And one more thing which we see as the aim of this collaboration is to support implementation of medical device regulation. We are aware of new medical device regulation in the European Union, and we know what kind of shift this regulation will require. So we think that this clinical engineering collaboration on a regional level will give sufficient guidance in this field as well. So I somehow made benefits from all of these three aims. And these were mentioned across the presentation of other colleagues, because with knowledge-empowered network, you have this exchange of best practices and know-hows among professionals. If we work on standardization, we could possibly go into reducing costs and increasing productivity in healthcare institutions. We all want the healthcare to be to have very good quality, but also efficiency in terms of finances. And if we are talking about support of implementation of medical devices, this digitalization that I mentioned is one thing that needs to be tackled. We are talking about inventories, we are talking about the digital databases regarding medical devices, and those are the things of the future that needs to be addressed. So in these points, we as a society think that international clinical engineering collaboration would be beneficial. So thank you very much.
Thank you, Leila. You also mentioned so many interesting points, starting from a critical and very clear picture of what have been the main criticalities in the emergency of COVID-19 in your country. Very interesting point about the emergency use authorizations. We had the same struggle here in Italy about, there was a national law giving emergency authorization for face masks and other PPEs, but it was read by some management of hospitals like everything is open. So the patient ventilators and other devices, they were not covered by an emergency use authorization, but we have seen all kinds of stuff entering the country without CE mark or with instructions for use and the display in Russian or Chinese or whatever. And this we tried to do as much as possible as clinical engineers, but it was concited times and very difficult. Maybe now we can face this kind of issues in a more strategic way, and I think this point is very important. So thank you so much, Leila. Unfortunately, Umberto Nocco from our association cannot join tonight, but I think it's clear that our position as Italian Clinical Engineers Association is towards a full support of a European federation and also the Global Clinical Engineering Alliance. We are willing to work towards this goal. I would like to ask Yadin David to join me again, just for a couple of closing remarks on his side, and then I will give the appointment to our next opportunity to meet. So Yadin, what's your feeling about this group of very dynamic, I think, European countries willing to collaborate at international level and sharing experiences in clinical engineering?
Stefano, this was an amazing session. You literally crisscross Europe from east to west, from north to south, and you got some very interesting ideas and comment. To begin with, there seems to be a need for cross-European exchange of information and better collaboration. There's also seemed to be very strong understanding of the value added and the benefit from international collaboration. And overall, these two concepts of European region under Global Clinical Engineering Alliance, for example, can bring forward the idea that the alliance would be consistent of an Africa division, America division, European division, Asia division, etc., etc., and therefore strengthen further the message we heard today, going towards policy makers and decision makers in the area of technology and its management. I think it's important. I think that we have an opportunity because of COVID-19 that, unlike previous time in the history, we have an unfortunate example of what does it take and how can we work together towards the new lessons learned. And we need to grab that moment and put in place the structure so we can put things that Laila talked about, the knowledge empowerment network. Aris talked about the collaboration between emergency use of medical devices. And Christophe was talking about the overall burden and other comments about fatigue, post-pandemic fatigue. Everybody sharing common element. It's not unique to one country, not unique to one region, but to all of us. And we can grab this momentum and build upon that a good infrastructure that would share knowledge, best practices, and therefore bring good lobbying for our profession. I'm happy that I was part of it.
Absolutely, it's momentum that we must leverage. So in terms of momentum and new opportunities to meet, I would like to give 2 appointments before I close this amazing session. The first one is in just 2 days, on Wednesday the 29th, we will make circulate the flyer. We are having a webinar. It's at 6 p.m. UTC time, and it's the title, Why GCA is Important for Our Profession. So this is going to be another occasion to talk about international networks and GCA in particular. And the other appointment I would like to launch to all the participants of the session today is our National Congress in Milan, the 11th to the 13th of November, so in 2 months from now. It's a very good chance to meet in person. Milan is easy to reach. We would like to have you as our guests in Italy to make another step towards this European alliance and international networks. So as a closing remark, I would like to thank Diego Bravar, who put together this program of the EuroBioHighTech here in Trieste. And I would like really to thank Yadin for co-chairing the session with me and all the colleagues that participated all across Europe. It was really amazing seeing you again after some time, feeling that we are still on the same page with these efforts, that we share the pain of the difficulties that we had, but the momentum is good, and so let's keep pushing towards this ambitious but realistic goal. Next appointments I gave. Thanks really to everyone and to all the people that is following us online in this session today, and hope to meet you soon in other networking opportunities. Thank you so much, and goodbye on my side.